Diverticulitis. Okay, it's actually a relatively short and sweet topic, so we're not going to be here super late. There's not a lot of terribly new stuff out there on diverticular disease, but it is something to kind of be aware of. What's new isn't really what we do. What's new-ish is what's done after we make the diagnosis. So it's probably worth kind of knowing what to expect if you have to make phone calls to people. But diverticular disease is a kind of an interesting entity, and it's basically a Western entity. It's not something you see that often in developing countries because our diets are quite different. And it turns out that diet is a big factor in developing diverticular disease. There's also some ethnic things that are interesting about diverticular disease, and in particular, Asians, for some reason, and it's not entirely clear, get more right-sided disease than non-Asians. Everybody still gets more left-sided disease than right. But Asians tend to get a little bit more right-sided disease. So it's not surprising to see, it shouldn't surprise you to see, that sometimes you'll get a true diverticulitis on the right in somebody you're working up for appendicitis perhaps, and they happen to be of Asian origin. So it's kind of an unusual, interesting thing. As far as why do we get it, diet has a huge impact on this. And I was taught I pulled out my old medical books, and I was taught back 30 years ago that one of the things you were not supposed to eat if you had a risk of diverticular disease or had diverticular disease was you weren't supposed to eat nuts, and you weren't supposed to eat popcorn, and because those little goobies would go down there and stick in the neck of the diverticulum, and it would be terrible for you, and it would make you worse. And I was also taught that about appendix, too. Don't bite your fingernails because the fingernail might go down and stick in the neck of your appendix and give you appendicitis. I mean, crazy stuff, just crazy, crazy stuff. It turns out that you can eat as much flippin' fiber of whatever kind of fiber you want, and it is a wonderful thing as far as at least particularly preventing diverticular disease, but it certainly doesn't make it worse. So fiber is in, real deal fiber. Now, people need to know what fiber is, so sometimes it takes some education on folks, but you can have the popcorn when you go to the movies. That's all well and good. Eat the nuts, eat the breads, have your apples. I carry an apple around with me all the time. Eat things that are full of fiber for you, and they're actually quite good for your guts, so fiber is good. Where is the most common place somebody gets diagnosed with diverticular disease? Oh, I'm here. Okay, I hear it. How many of you, what is it about your 50th birthday that they managed to get the AARP card in your mailbox on your 50th birthday? I got my AARP card application in my mailbox on my 50th birthday. What also happened on my 50th birthday was I suddenly dropped right onto that lovely little healthcare maintenance sort of plan of my colonoscopy was due and all these lovely things you're supposed to start doing. So most diverticular disease is walking around totally asymptomatic and diagnosed on colonoscopy. Okay, that's where most of it is. It's not diagnosed by us. It's diagnosed in colonoscopy because there's a whole lot of people walking around with asymptomatic diverticula. Okay, a whole bunch. Lots of people are out there with this. In fact, the statistics are by the age of 80, 70% of people raised in Western areas have diverticular disease. Okay, it's just what we get. So it is definitely, now, if most people are walking around with no symptoms, what can happen, theoretically, and the theory is what happens is a little bit of stool gets stuck in the neck of the diverticulum, which is a place, the bowel itself, if you think about your bowels are actually kind of interesting. Your small bowel is like a stack of coins as far as how the muscles work. Okay, those are those plicae circulares. They're actually true rings of muscle all the way down your small bowel that squeeze along and get that stool that's very liquidy, as it's sort of all the stuff's getting absorbed, gets it down through the small bowel, 60 feet of that. Then it hits your ileocecal valve, and it gets into your large bowel, and the muscles change. So in your large bowel, the muscles are no longer completely circumferential. They run longitudinal. And if you ever look at a piece of large bowel, there's a band, several actually, bands of muscle that run the length of the muscle. And there's some that go circular, but not all the way around. That's why you see those Halstri. When you see large bowel, you see the little, looks like little bits of sausage that kind of get along there, but it doesn't go all the way around like a ring. Where those muscles are along the bowel, there have to be penetrating blood vessels that come through to perfuse both the inside of your bowel and the outside. It's those penetrating places where you get diverticula. It's where the vessels come through penetrating through this muscularis layer. So if you get outpouching through that layer, you basically get this little balloon that has a neck of it that's through a muscle layer. If that gets jammed, with something that sticks in the neck of that thing. So just a piece of stool. If it gets stuck in there, what will happen is the normal gut flora that are sitting in your guts right now, okay, the E. coli that's living in there and all the other things, will have a little place to have a party. And they start to proliferate in that little diverticulum, but they need to go somewhere, and there's no place to go. So it gets distended, will microperforate, and then can macroperforate and give you abscess and phlegmon and sepsis and peritonitis and sick. So the spectrum of diverticular disease makes sense. Makes sense. You go from most people are just fine. You're walking around, you don't even know you have it, to, oh, I got a little bit of pain. It's usually on the left, right? Because it's in your large bowel. Usually, if you're non-Asian, it's on the left. Actually, even if you're Asian, it's usually on the left. It hurts when I have to have a bowel movement. Once I have a bowel movement or I pass flatus, it gets better. That feels better. That's painful diverticular disease. It got stuck. It's a little bit inflamed, no big deal. Not truly itis. Then you get microperforation. Now you are pretty focally tender on exam. You may even have a low-grade fever. Then you get really tender on exam. Now you've perforated, and you can get, frankly, peritoneal. So that's the spectrum of diverticular disease. And what's interesting for us in the emergency department is figuring out where is it that I need to go crazy doing tests and working people up, and where is it I can say, yeah, good on you, probably you're not so sick, we'll send you home. And we'll talk about that because there's some data on that. That's the spectrum. In that spectrum, at any point in time, bleeding can happen, and it's unrelated. So diverticular bleeding, and again, it's going through where the vessel perforates through into the gut, so through the muscle wall, so that can actually bleed, just like the angiodysplasia can, the two sort of common causes of lower GI bleeding, gross lower GI bleeding. Those are unrelated phenomena. You don't get diverticulitis and bleed usually. It's usually unrelated, one thing to the other. They don't tend to go together. So presentations of diverticulitis starts, sort of next sort of as we go through this, that there are people who present atypically. The people who present atypically are the people that you and I would all make the correct list of. They are immunocompromised people. They are people who are HIV positive. They get that. Older people are classic for presenting atypically. They just aren't eating very well today, or they just vaguely feel poorly, or they have their whole belly feels just a little bit uncomfortable. They tend to present atypically. So just be aware of those patient populations that are particularly problematic. If you have somebody in the ER who comes in, and they say, okay, I'm 60 years old, and I've had some sort of little bit of discomfort over here, but now it's constant, and it's really bothering me. What studies do I need to get on that person? Well, there are guidelines out there, because there are guidelines on everything on the planet out there, and there's called the Standards Committee of the American College of Colon and Rectal Surgeons. And what they've decided the minimum workup should be, just as a baseline for everybody you're worried about diverticular disease, is to get a UA, a CBC, a pregnancy test if it's a woman of childbearing age, and plain films. I think that's fascinating. Most of us don't get plain films anymore. The reason they want to get plain films actually has a little bit of basis in fact. The thing about diverticular disease is it does perforate, so you may see actually free air. The other thing about diverticular disease is if you get to the point of abscesses and things, it is the third most common, well actually the second most common cause of large bowel obstruction. Most common cause is cancer. Second most common cause is a complication of diverticular disease. That begs the issue, though, if somebody has a complication of diverticular disease, that may not be the best imaging study to get me what I need to know, which is, give me the anatomy here. Show me where the lesion is exactly. Don't give me a plain film that says you've got some obstruction. Now I need to go get more studies done. So that's their basic thing, and I don't quite agree with the plain films, but the other stuff is just fine. They do say, God bless them, if somebody has mild diverticular disease, and that includes, it's just a little bit painful to maybe even a little bit of localized tenderness, but no guarding, no rebound, they're not that sick, not febrile, they're not vomiting, you can control their pain, don't image. And they say this, like honest to God, they say, truly, no need to image. It's shocking. They actually say you don't have to. And those of us, I've been practicing for 28 years or so. Back in the day when I started practicing, we didn't scan all these people. I mean, we said you have painful diverticular disease. Here's what I recommend you do at home, which we'll talk about in a minute. But here's what I recommend you do at home. Go forth. You are fine. Go forth. And they did fine. We got crazy about imaging when we got the chance to image everything. And we don't need to image people who have transportation, they're not febrile, or they have a very low-grade fever. They are minimally tender, they don't guard or rebound, they aren't vomiting, you can control their pain, and they can get back to you. They can come back, they have a car, so they're not a homeless person on the street, they actually come see you. That patient does not need to be imaged, particularly if they say, oh, you know, when I had my colonoscopy after I got my AARP card and went and got my colonoscopy like I was supposed to, I had diverticular disease. They told me I had that tics thing. Great. Now I know you have those, and you are only mildly sick, you get to go home. Okay, so you don't need to image everybody. You absolutely don't. However, if the diagnosis is unclear, or if the patient is moderately to severely ill, you really do. Because there are certain things that change your management based on what you find on there. So the moderately sick, the very sick, and the I'm not sure what's wrong with you group should probably go ahead and get imaged. Now, should you use oral contrast? We talked about this on the panel, and I will, write this down, my email, write this down. If you want to fight your oral contrast battle, I will send you the LA County guideline that has been developed that says when you need it and when you don't. Same thing, by the way, with getting a creatinine in certain patients as well. My email is DianeB, D-I-A-N-E-B, at emedharbor, E-M-E-D, harbor, like a boat harbor, HARBOR.edu. DianeB at emedharbor.edu. I will send you the guideline that was a consensus, basically the county adopted this policy on who needs oral contrast and who doesn't. That is quite reasonable, and in fact, probably a little bit errs on the side of contrast in some patients. We really don't need it, but there's do not need it, absolutely need it, think about it. 3 different groups they divided into. And it's Greg said it's worth fighting the battle, or Mike Menchine said it's worth fighting this battle. It is. We slow down people coming through the ER all the time. So oral contrast buys you virtually nothing when you're working at people with diverticular disease. It doesn't help you a whole lot. Maybe with the IV does as far as abscesses are concerned, but overall the IV contrast doesn't help you. My favorite paper in here that looks at this is number 2. And let me just tell you the premise of the paper. What they did with this paper is and I'm not sure how they got this through an IRB, but they took 100 adults where either diverticulitis or appendicitis was the concern, totally fine, and they randomized them. Well, they didn't randomize them. Each patient got a non-con belly scan with IV only, and then got another scan with PO contrast as well. I don't know how they got that through an IRB, but they did. And what they did then is they took 2 radiologists and had them read them and say, okay, compare those 2 studies. Did you get extra information by having the oral contrast done? And of these, they had 21 scans where they said, oh yeah, definitely. There is definitely something extra I got by using that oral contrast. And they list, here's why I think it is beneficial, blah, blah, blah. And if you stop there, you would say basically 20% of scans have improved readings by being given oral contrast. And we would all be giving oral contrast every day of the week. What they did in this study is they said, wait a second. Okay, great, cool, fine. Good on you, you 2 radiologists, wonderful. We're gonna talk to these radiologists over here though, now. We're gonna take those scans and we're gonna have them read them and see what they think. And what it turned out was the benefit you got in the scans was because the radiologists differed with each other, not because the study was any different. It was an inter-rater reliability problem, not a study problem. So the problem we have isn't the study. The problem is our radiologists not agreeing with each other. And the statistics, so you know, on anything short of plain films, of orthopedic plain films, so chest x-rays, plain belly films, CT scans, CTPAs, whatever. The disagreement rate is usually about 10 to 15%. From one radiologist to the next, one will find something, the other one will say it's not there what they think they found. So that is just a background noise, and it's probably the background noise of radiologists disagreeing with each other much more of a problem than oral contrast or not. So the oral contrast doesn't give you a ton. What about ultrasound? Turns out there's some data in here that looks at this. Ultrasound for diverticular disease is actually quite good. And our ultrasonographers are getting better and better and better at looking for stuff in the belly. They're getting better at appendicitis. It's the study of choice in most children now to rule out appendicitis. And they're getting really good at it for diverticular disease. They can see the abscess, they can see inflammatory changes. They're actually quite good. So it turns out that if you have a good ultrasonographer and a radiologist who can read them, and they're all getting better, all of this, it's worth considering an ultrasound. So CT scans are still what most of us defer to, which is fine, but ultrasound actually is not a bad option for people. And the data that looks at it in areas that know how to do it and are comfortable with it, they're almost equivalent. as far as diagnosing diverticular disease. So know that that's out there as an option. Yeah.
How about the negatives, though? Because it's like appendicitis. Who do you decide to stop on there?
So I think that is your pretest likelihood. So if you're getting it, it's like, well, you know, I'm not sure they even have diverticular disease. They're not that sick. I'd like to sort of see if there's anything scary down there, and there's nothing that they can find. You're done. If it's like, oh, no, I'm worried about this person, and yeah, your sono may be negative, but I'm still too worried to say I'm finished here. So that, again, it's a pretest, like in everything. It's a pretest probability thing in that. And you also need to know your your practice environment. We have one ultrasonographer who couldn't find her way out of a box, and she just can't. Poor thing. She just has trouble with it. But the rest are great as far as our ones that come in and do our ultrasounds. So you have to kind of know your milieu, and your radiologist also. You have kind of to know who knows what they're doing in that. CT but if you're doing CT in most people, it's completely fine for study. It's just if it's a younger person, you may not want to CT them overall. And then can you send them out as outpatients? Is it safe? Absolutely. And there's a couple papers in there that look at this, sort of abstracts 7, 8, 9, et cetera. The best of them is abstract number 8, which looks at a review of 4 studies at outpatient management of people that have diverticular disease. And they said exactly what the American College of Gut people said, which is if they can tolerate POs, if they have no significant comorbidities, you can control their pain, they have adequate social support, and they don't have a significant fever, they go outpatient treatment, and the treatment is PO-only fluids for a couple of days, so you're not stressing that already kind of stressed out intracolonic pressure area of the bowel, and then advance their diet over several days, and you will send them home on antibiotics. The antibiotics at home are either Flagyl plus a quinolone or Bactrim, or moxifloxacin or Augmentin as sole agents as outpatient therapy. So those are the recommended drugs to be used as an outpatient. Sick people need to stay in the hospital. Now the problem with sick people is things are managed very differently now than they used to be, and your scan will make a difference in those people. Your imaging to see if they have an abscess or not will make a difference in those people because there's now a different approach to diverticular disease. And that gets sort of the end of this thing. I've worked 4 shifts, as I've known you all, this 4 days we've been together. I worked Tuesday, Wednesday, Thursday, Friday, 4 to 12, all 4. One of the bad things about doing a conference in your hometown is that you can get snagged for shifts. So I've been here in the mornings with you, and I've been there in the evenings. Yesterday, we had this is my patient population, and this is something if you work with Hispanics, you need to be aware of as well. They get diverticular disease younger than we tend to think of diverticular disease. It's probably dietary, we don't know exactly why, but they get it younger. Yesterday was a 32-year-old woman who came in with basically, she was complaining of rectal pain. We thought it was going to be a perirectal abscess, and she was very tender on rectal exam. She was a little bit tender in her belly, but not too much. Pelvic exam, a little bit tender, but not too much. It was sort of this differential of perirectal abscess, TOA, and it was all sort of left lower-ish area. She had the biggest phlegmon from ruptured diverticular disease I've seen in quite some time. Remarkable. We went through the whole rigmarole of ultrasounding her first because we didn't want to radiate a 32-year-old woman of childbearing age and blood. We went through the whole 9 yards that we all go through in the decisions, and I'll be darned if that scan wasn't dramatic. It was a big phlegmon. It was like, we need to operate phlegmon. She got septic. She got really sick last night. The thing about the reason that the scans, or at least imaging, is helpful is nowadays, you used to call surgeons. It was routine, right? The surgeons are the people that manage diverticular disease. So you'd say, Dr. Blade, hi. It's Diane here in the ER. I've got a patient here for you who has, a ruptured diverticulum, it's walled off abscess. Come on down. And the answer now is going to be, first question is going to be, how big is the abscess? And if you say it's 3 centimeters, they're going to say, great, call the hospitalist, call IR, have them consult me in the morning. And that's not wrong. What's changed in the last 5 years or so is that the approach to complicated diverticular disease, where it's actually ruptured, where there's truly an abscess, is nowadays what they're doing, instead of doing primary surgery, which is what they used to do quite a bit, is that they found that what they had to do with all of those people is do a diverting colostomy so that they could, get and take out that segment of bowel, and then do a reanastomosis procedure 6 months to a year later. Weirdly, about half of people never get reanastomosed. I mean, I would think, I don't know, if I had a colonoscopy or a colostomy, I think I would want to go back and get that, if I could, get it put back together. They don't. There also were complications of abscesses, et cetera. It turns out that what's better, either in the really comorbid sick person in whom surgery is a very high risk, and that can be an abscess of almost any size, or even in a normal healthy person with an abscess of 4 centimeters or smaller, what they're doing now is admitting them, putting them on IV antibiotics, and draining it through IR. And what they're finding in that is that particularly for the younger healthy people, they get chilled down, they get that abscess drained, they wait a reasonable period of time, usually a week or 2, and then they do 1 surgery. They take out the bad loop, they put you back together right then and there, you don't have a diverting colostomy, and you have a single procedure taking care of the problem. The data is pretty good on that approach. So if I were to come up with diverticular disease tomorrow, and I had a 3 centimeter abscess, if they said, surgeon is gonna see you in a week or 2, the hospitalist and the IR guy are gonna take care of you in the meantime, that's actually a decent approach these days, and the data, it's in here, and the data's pretty good on this. Diverticular disease, most of us get a little blasé about it because most people are fine, antibiotics are cool, we admit them. Every once in a while, someone goes south in a big way, and I have his permission to tell you, but one of the most people that we all are aware of who went south on this in a big way is Jim Roberts, as in Roberts and Hedges fame, almost died of diverticular disease. He had diffuse peritonitis, he had ruptured the diverticulum, he was intubated, he was on pressors, he had a colostomy for a year. He was sick as a dog. This is a real deal disease. In some people, they get incredibly sick. So just know that, and we know this, but it just takes 1 or 2 of those every once in a while to remind you that something we get a little blasé about is something that can be a really serious problem. The last 2 abstracts actually of the course are a point-counterpoint. I love this, the last 2. These are basically 2 editorials that address the question, if you have had an episode of diverticulitis, do you need a follow-up colonoscopy? Then this, I can't remember which journal this one's in. It's in Diseases of the Colon and Rectum, which I'm sure you all subscribe to. This one, a lot of the journals will do this. They'll posit a question, and then they'll have 2 experts take a pro and a con approach. So they said, the question was, do people who've had diverticulitis need a follow-up colonoscopy within 6 months? And one of the guys says, oh, absolutely. Really important to do. We need to take a look in there. They might have cancer. We need to make sure that's not what's going on. And the other guy says, are you crazy? Seriously? They have the disease. We just diagnosed the disease. We just took care of the disease. They don't need that. And the risk of cancer is no different in that patient than it would have been if they didn't have diverticular disease. So it's not any magic thing. If they haven't had a colonoscopy to be surveilled, sure, go for it. But otherwise, you don't have to do it specifically because they've had diverticulitis. So eat your fiber. Okay, make sure you eat your apple every day. Eat your fiber. And this has been delightful. I have to tell you, this has been a complete delight. Thank you very much.